Right. Okay, so this is the right second eye of patient number 2. So we do a small incision in the side. It's 2.75 millimeters. It has to be deep enough to be self-sealing. And that's the angulation of that depends on the corneal thickness. Look at the light. Keep going. I'll give you some freezing here. My friend is gonna bite a little. This is the one. That's the freezing. So this is preservative-free xylocaine and phenol 10 mix. It bites because the inside is not frozen. Now it's frozen. So I'm going to continue. This is a viscoelastic material. It's a thick, what we call undercoat. So it coats the cornea, and I coat the front of the cornea so that the nurse doesn't need to keep squirting fluid on the cornea to keep it wet. This way she doesn't have to be committed to that. And now we create a second incision. Second incision is about 0.9 millimeter, through which we're gonna be using a second instrument to do it during the surgery. There you go. So this mark is to mark the size of this rhexis, the opening, so that it would cover the size of the lens. For example, his cornea is very big, it's 13 millimeters compared to other people. So if I just eyeball it, it's going to end up with a really big rhexis. So we have to measure that rhexis so that we do an appropriate size opening, so that it would cover the lens all around. That helps lens stability and decrease the chance of opacification of the capsule. So go around, and this is a very important step, that one, to open that nice circle incision that's appropriate size and in the center. Now I'm going to split the layers of the lens with hydrosection and the hydrodelineation. So I'll go underneath. Under the capsule, I split the layers of the lens from the capsule, so now the lens can rotate. And then I'm going to split the nucleus from the epinucleus, so that we have multiple layers that we can deal with separately in a safe fashion here. Can you pass me the scissors? The drape is in the way here, so I'm just gonna make it bigger a little. There you go. Now we're gonna use the phaco handpiece. So this handpiece, what it does, it irrigates and aspirates and vibrates. So three actions here. Step one is start irrigating. So I'm gonna start continuous irrigation here. Okay, I'm going to go with the second piece. This is the way we do the second incision. And I'm just going to get rid of air bubbles. So we're going to divide the nucleus. So now I'm taking the nucleus in, fixating it, and splitting it. So see the split? Split it in multiple parts, quadrants or thirds, or to get to each piece to be removed on its own. So here a piece, so the first piece is the most difficult because there's not much space to maneuver the pieces, but now it's gone. Now I have more space to move the pieces in. Now I can move a bigger piece because I have more space. Move it and bring it to the anterior chamber and eat it up there. Away from the capsule, away from the iris, away from the cornea. All the action is in the middle of this chamber, away from all the other important structures around. So rotate, split again, rotate and split. Okay, this is the last big piece, there's a smaller one behind it. Okay, so now the epinucleus is the softer outer part. I'll leave it behind to protect the capsule while I'm doing the big hard pieces. This is a softer one. It's mostly moved with just irrigation, mostly aspiration. Okay, now I remove the nucleus, the epinucleus. We're left with the capsule and cortex. cortex has a very soft fibers in the outside here. So I'm going to clean it up with the J cannula. J cannula irrigates. If you look here, it's just going to push fluid back at me, right? So it's going to push back fluid into the wound where the J cannula is going in. So go in. It will go around the capsule and split the layers of the cortex from the capsule, leaving the capsule nice and clean. Other surgeons would use aspiration at this stage, but this capsule is very thin. It's anywhere from 20 microns to 3 microns, down to 3 microns. And so if you capture it with doing the irrigation aspiration, you can actually open the capsule and result in complications. So I prefer to use that J cannula so that we avoid that kind of complication. Okay. Aspiration is much safer than irrigation. Irrigation is much safer than aspiration, sorry. Now the lens goes in through this small incision. So this incision is 2.7, but the lens is 6.5 optic and 12 to 12 millimeters from haptic to haptic. The haptic is the leg of the lens. So it goes in folded and start opening. So those legs will open and keep the lens in the middle. Okay. While the optic opens, and we want the optic to be covered by the rexus edge we measured and cut in the beginning. Okay. So let's go there. Okay. So now I'm using the lens to remove any other fibers safely that way. So I'm rotating it, putting it in the horizontal position. Usually I like to do that. Okay. I'm cleaning behind the capsule, behind the lens. Okay, so the lens is nice covered with this edge. Lens is very well centered. Okay, now I'm going to hydrate the wound to get them to swell and close down. I'm using an antibiotic here, the moxifloxacin. Look at the light. All right. So this is why the wound is hydrated and closed with the antibiotic. So it acts as a guard. I filled the chamber with that antibiotic, so it kills any bugs that can go in. Most important thing is to keep the wound closed. So that's why the patient shouldn't rub their eyes. If they rub their eye, they open the wound. Okay. So, okay. Pressure is okay. Now we inject the dropless injection. It's a long-acting medication. Okay. So this give you a super dose of antibiotics and steroids to guard against infection and inflammation. And that's it, done. Both eyes went great, my friend.